Hello and welcome to a film review for the pelvis, hip, femur, and SI joint x-rays. Now we've got a lot to cover in this video and it does get a little bit long, so if you need a break, remember to pause, get up and stretch, take a break, and then come back when you're ready. So first things first, there are 8 required projections that I need you to know for checkoffs in lab week 3. So we're going to learn pelvis, a couple for the hip, a couple for the femur, and then the SI joints. So 8 required for checkoffs. However, there are 5 special projections that we don't need to check off on, but I still need you to know them for the exam. So we'll cover these 5 special projections at the end. Let's get started. So we're going to start with the pelvis. AP pelvis, and in many respects you already know how to do this. It's the bottom half of a KUB or of an abdomen x-ray. So when you're performing the AP pelvis, we are going to use 14 by 17 landscape collimation or landscape IR orientation. We are going to use 45 inches SID in our lab because the manufacturer recommended 45 inches SID for our Siemens equipment. But remember, many clinical sites are still using 40 inches SID, so just be flexible and adapt to whatever SID your site uses. As you notice in the picture here, you can do this standing or recumbent. For checkoffs, we're going to do ours recumbent to simulate an injury. And where do we center? Well, your central ray should go 2 inches below ACIS and mid-sagittal plane. So you're going to find ACIS, okay? You're going to center 2 inches below ACIS and then mid-sagittal plane. And remember, you can always divide your image into quadrants, and that gives you an idea of where the central ray was placed. So right about here. We are going to use approximately 10 mass at 73 kVp, but remember that's going to vary depending on the equipment you're using and your patient's body habitus. So when you look at the finished radiograph, how do you know you're correctly positioned? Well, first things first, you need to make sure you've included all of the anatomy. So very basically, we look for iliac crest. Have a little bit of space above iliac crest. We want to make sure we've included pubic symphysis here. And notice our ischial tuberosities sit a little bit lower than pubic symphysis. You need to make sure you include ischial tuberosity as well. I also like to look and make sure, again, that I have equal spacing on either side of my pelvis, and that tells me if I was centered correctly on mid-sagittal plane. We also need to make sure we've included the proximal 1/3 of each femur, as you can see here. Okay, so very nice. Notice our marker placement is typically in the lower corner. If you put it in the upper corner, sometimes you can get into that wing or that crest, and we want to avoid that because that would result in a repeat radiograph. When you're positioning for an AP pelvis, we're going to ask the patients to rotate their feet 15 degrees internally. So kind of separate their heels, turn their toes in. Why do we do this? This is important. In anatomic position, our femoral head and neck lie at a 15 to 20 degree anterior angle. So you can see that in the diagram here. So femoral head and neck sit 15 to 20 degrees anteriorly of the femoral body or shaft. And that's anatomic position. The problem with anatomic position is when we x-ray a patient in that position, the femoral neck then appears foreshortened, and it makes it difficult to evaluate or assess that whole femoral neck region. So we ask the patients to turn their feet 15 degrees internally, and as a result, it places the femoral neck parallel to the image receptor and makes it much easier to visualize that whole area. Now there's another thing I want you to notice. When we rotate the feet 15 degrees internally, in addition to placing the femoral neck parallel to the image receptor and reducing foreshortening, we also rotate the lesser trochanters behind the femoral body or shaft. So you can look at this radiograph and see we only see a little tiny bit of the lesser trochanter. That is a clue to me that they have indeed rotated the feet 15 degrees. Now, we do not rotate the feet 15 degrees to hide the lesser trochanter. That's not why we do it. We rotate the feet 15 degrees to place the femoral neck parallel to the image receptor. As a result of the 15-degree internal rotation, the lesser trochanters become hidden. Now, on some patients, you still see them a little bit poking out here, but this is much better than anatomic position. And let's look at some examples here. So, you can see on the left here, this is when we rotate the patient's feet in 15 to 20 degrees. You can see the femoral neck is now not foreshortened. It's parallel to the image receptor. You can see that area nicely, and the foot is rotated in. By the way, I typically don't use sandbags, but they are available to help if you need them. But let's compare that with B here on the right. Notice when the patient's leg is externally rotated, the neck appears much shorter, so it's foreshortened, and we can see that very prominent lesser trochanter. So this is what we want to see. We want to see A in a correctly positioned pelvis x-ray. And again, we're going to do that on both sides, right and left. Now, I referenced anatomic position several times. Notice the patient here is in anatomic position. Okay, so the feet are just pointed straight up. Notice the femoral neck is slightly foreshortened on both sides, and you can see that lesser trochanter really prominently. Again, in a true AP of the proximal femur, we don't want that femoral neck foreshortened. We want to see that femoral neck parallel to the image receptor. So in a true AP of the hip, we're going to turn those feet in 15 degrees. Now, here's another example of external rotation or relaxed position. Again, just so you can see, this is the feet are rotated externally. So you can see the femoral necks are foreshortened and the lesser trochanters are visible. Again, this is what we want. We want 15 to 20 degrees of internal rotation. So the toes are together, the heels are separated. It prevents foreshortening of the femoral neck. And notice it really hides those lesser trochanters. Now again, on some patients, they're still slightly visible, but on many patients, it completely hides that lesser trochanter. Now, some patients, especially your elderly patients, may struggle with this 15 to 20 degree internal rotation, but just have them do the best they can because it's really important to place that femoral neck parallel to the image receptor. Now, you may see a patient come in to the emergency department with asymmetric rotation. So notice the right leg here is in anatomic position, but the left leg is externally rotated. That is one sign of a potential hip fracture. So when we see this asymmetric rotation, we x-ray the patient as is. We do not ask them to turn this leg 15 to 20 degrees internally. Okay? If we're suspecting a hip fracture, we do not turn the feet in. We just leave it as is. And you can see in the example here on the left, the patient does have a hip fracture. Okay, good. Moving along, let's next discuss the AP femur. When you are imaging the femur, we are now switching our orientation or our collimation to portrait. Okay, so we're going to use a 14 by 17 inch portrait image receptor or portrait collimation. But most adults will not fit on one 14 by 17. The femur is just too long. So you have a couple options because remember, you always want to make sure you're overlapping so you're not missing any anatomy. So you could certainly use two 14 by 17 inch image receptors, one to get the proximal joint and one to get the distal joint, but you're going to overlap more than you need there, and that's over radiating your patient. So a lot of times what we'll do is we use a 10 by 12 inch image receptor or collimation and a 14 by 17 inch. And typically we'll put the long film or the 14 by 17 inch collimation at the area of injury or the area of the prosthetic. and then we'd use the short image receptor to capture the opposite joint. So for example, if my patient came in and they had distal pain and we were suspecting a distal fracture, I could use my 14 by 17 inch here, and then I'd use my 10 by 12 inch to get the hip joint. Or vice versa, if the patient has a prosthetic hip in place already, remember you have to include the entire prosthetic in your image. So you could use the 14 by 17 inch collimation proximally and the 10 by 12 inch collimation distally to get the knee joint. Okay, so just use your discretion. Now, we're going to use 45 inches SID in our lab. Remember, as I said earlier, some clinical sites use 40, so just adapt to that. Now, where do we center for a femur? Well, notice our textbook says center at mid-shaft. Well, that's kind of confusing and misleading because that's only applicable if you are obtaining the entire femur in one image. Remember, most adults were not. So rather than centering at mid-shaft, I would encourage you to perform a kind of a long hip x-ray, which we'll learn hip just in a few minutes. So basically position for a hip and then center a couple inches lower. And when you're doing the distal femur, you're going to find the knee joint. Remember, you find the patellar apex, so the bottom of the patella. Put your finger there, that's the knee joint. So you're going to make sure the knee joint is at the bottom of your image receptor, and then you're going to extend your collimation all the way up as far as you can, making sure you overlap in between the two. So in other words, when you're doing a femur on most adults, you're going to do a low hip and a high knee, basically, okay? So how do you know you're correctly positioned? Well, you have to include all of the anatomy. Remember, when you're imaging a long bone, the only way to ensure you've gotten the entire bone is to include both joints, the proximal and distal. So you have to include the femoral head and the acetabulum. That ensures that you have proximal femur. And you have to include the knee joint because that ensures you have distal femur. Remember, you always want to make sure you have overlap in the middle of your two images again so you're not missing any anatomy. Remember, on the proximal image or the proximal femur, you're going to rotate the patient's feet in 15 degrees or the affected limb in 15 degrees. That's going to place the femoral neck parallel to the image receptor and hide that lesser trochanter as a result. And then when you're doing the distal femur, you want to position the knee in a true AP. And remember, a true AP knee is going to have slight 3 to 5 degree medial rotation. You want to see the tib-fib slightly superimposed and the patella should be centered. Okay, so this is your AP femur. And then, of course, we need to do a lateral. Now, same thing, we're going to use 14 by 17 inch portrait collimation, but really for most adults, we're going to do two images. One could be our 14 by 17 and then a 10 by 12 to include the other joint. Remember, our long film should include the area of injury or the prosthetic. 45 inches SID, again, our textbook says center at midshaft, but really that's not applicable for most adults. That would be applicable for pediatrics who can fit on a 14 by 17, but not for adults. So notice what they've done in the picture here. The bottom of their light is just below the knee joint, okay? And then they've extended as far up as they can. And then they're going to get the proximal femur using a 10 by 12. Okay, so two different images. So how do we know we're correctly positioned? Well, again, you need to include both the hip and the knee joint, and both joints should be in a lateral position. So if you look at the image here on the left, we are clipping the distal part of the femur, so we would need to repeat that. And we are clipping the proximal part of the femur. So again, we'd need to repeat that. So this is a great example of why two images are applicable in most cases with most adults. Now, we already know what a lateral knee should look like. We'll talk about what a proximal lateral femur should look like in just a few minutes. Okay? So, hip. Let's talk about hip. Now, when we say hip, That is the same thing as saying proximal femur, okay? Those two terms are interchangeable. For a hip x-ray, we want to see about the proximal 1/3 of the femur. So we only need to use 10 by 12 portrait collimation. So 12 inches tall by 10 inches wide. Again, we're going to use 45 inches SID in our lab, and we are going to center mid-femoral neck. Now, that is very difficult, obviously, to palpate, so we're going to talk about some tricks here in just a second to find the femoral neck. And our technique is approximately 10 at 77. So how do we know we're correctly positioned when we do a hip? Well, again, as I said, we want to include the proximal 1/3 of the femur. Remember, we talked about this with the pelvis. We're going to rotate the foot 15 degrees internally to place the femoral neck parallel to the image receptor, which prevents foreshortening, and as a result, it hides the lesser trochanter. We also want to see the greater trochanter in profile laterally, which you can see here. Okay? Notice we do not need to include crest. We do want to see that acetabulum really nicely here, and again, the proximal 1/3 of the femur. So let's talk about how do we find mid-femoral neck, because you can't palpate that. So let's look at some tricks. Okay, so there are two common methods to localize the femoral neck, which is where we want to center. So in method 1, you find ACES, and that's where this X is, and you draw an imaginary line to pubic symphysis. Okay, because we're not palpating pubic symphysis because it's uncomfortable and embarrassing for the patient. So you find ACES, draw an imaginary line to pubic symphysis. About midway through that imaginary line, you can go about 1.5 inches below to find the head, or 2.5 inches below to find the neck. Okay, so that's one method. Now for some people, that's a little bit too vague and they need a little bit more guidance. So the second method would be to find ACES, go in about 2 inches, and then go down about 4 inches. And that'll land you right at the femoral neck. So I'll show you how I do it in lab and how I learned and what works for me, but certainly either one of these methods will work. Another trick that I want to show, or that I just want to mention, is if you are collimated to 10 by 12 portrait, if you put the top of your collimation at iliac crest, you'll get the hip every time. But that only works if you're correctly collimated to 10 by 12. So let me say that one more time. Collimate to 10 by 12 portrait. You put the top of your light field at iliac crest, center down the middle of the leg. You'll get the hip every time. All right. Here's another example showing how to find the femoral head and the femoral neck. You can see find ACES, an imaginary line to pubic symphysis, come down 1.5 inches or 2.5 inches. Or in method 2, you find ACES, go in 2 inches and down 4. Okay? All right. So let's next look at our non-trauma lateral hip, because we just talked about the AP hip and we know we need to do the lateral. So we're going to use 10 by 12 portrait collimation. Again, 45 inches SID. We are still centering at mid-femoral neck, so we just talked about how to find that. This is called the frog, and you can kind of see why here in our model. This looks like a frog leg, right? I need you to know the method name. This is actually called the modified cleaves. So we call it the frog, but the method name is modified cleaves, and that's how you'll see it written on the test. So I need you to be familiar with that method name. So how do we correctly position for this x-ray? Well, you're going to ask the patient to bend their knee, and you're going to abduct the leg away about 45 degrees. So think about this as 0, okay? You're going to ask the patient to bend their knee and drop their leg out 45 degrees. This gives us a nice lateral perspective of the entire proximal femur. The problem is, look at how foreshortened the femoral neck is. So there's actually another projection that we can do to try to visualize that femoral neck a little bit better in a lateral perspective. But this is what we want to see. We want to see a third of the proximal femur. We want to see the acetabulum, and then kind of a general survey of that proximal femur hip region. So this is the modified cleaves. This is what I'd like you to check off on, but I also want you to know the done. And the done is done at some of our clinical sites. So everything is the same. It's 10 by 12 portrait collimation. It's 45 inches SID. You're still centering at femoral neck. The only difference here is instead of abducting the leg 45 degrees away, you're going to only abduct 20 to 30 degrees. This provides less foreshortening of the femoral neck, and you can see that here. So everything looks the same. We still call it the frog, really, for all intensive purposes, but the method name here is done. And let's go back and look at the difference. Here is 45-degree abduction. Okay, so the femoral neck is really foreshortened. Here is 20 to 30 degrees of abduction. And I think you can see the femoral neck much nicer. Okay, so I want you to know the done again because some of our clinical sites do perform this projection. So the only difference is the degree of abduction. The positioning otherwise is the same. All right, now the modified cleaves and the done are done in non-trauma situations. But certainly we know that, hip fractures are pretty common. We need to know how to image that proximal femur or that hip joint in a trauma situation. So how do we obtain a lateral in a trauma? Because we cannot ask the patients to bend or abduct. So this time we are going to switch to tabletop. So we've been doing all of these previously in our table bucky using a grid. Now we're going to switch to tabletop. We're going to do 10 by 12 landscape orientation. We're going to add a grid onto our tabletop projection. We're still centering mid-femoral neck. This time we're using a lot more technique, and it sounds crazy, but it works. We're going to use about 63 mass at 81 kVp, and our beam will now be horizontal. So before we go any farther, I need you to know that this is called the Donnelius-Miller method. Okay, remember the frog is the modified cleaves. The done is the modified cleaves, but with less abduction. This is the Donnelius-Miller. So notice the patient is recumbent on the table, of course, and the image receptor is placed parallel to the femoral neck. The top of the image receptor is placed at the level of iliac crest. We are going to center kind of right in the crease where the thigh meets the pelvis, and we are going to raise the unaffected leg out of the way. Okay, so you can use a foot holder. I've used a garbage can tipped upside down. I've used a chair. You can have the patient hold their leg, whatever works, but you got to get the good leg out of the way so that you can have an unobstructed view of that affected leg. So how do we know we're correctly positioned? Well, we want to make sure we've included the proximal 1/3 of the femur. You have to include the acetabulum. If you clip the acetabulum, that would be a repeat radiograph, so make sure you include that. And remember, our beam is centered at femoral neck, but our tube is here, and it's horizontally directed at our femoral neck and our image receptor. And of course, I'll demonstrate how to do this for you in lab. Okay. All right, let's transition now to the SI joints. So we are going to do AP-SI joints recumbent on the table using 10 by 12 portrait collimation. We'll use 45 inches SID. Our central rays should be located 2 inches below ACIS and mid-sagittal plane. Okay, so here is ACIS. Our central ray should be 2 inches below that and mid-sagittal plane. We're going to use about 10 at 73 for our technique. Again, that'll vary depending on your patient and your equipment. So to perform the SI joints, Remember, the SI joint is the joint between your sacrum, so this is sacrum, and your ilium. And this is your, remember your ilium is part of your pelvis or part of your hip bone. So we want to see the joints between the sacrum and the ilium. That's how we get the name SI, sacroiliac. When you're doing this projection on a man, we're going to use 30-degree cephalic tube angle, again centering 2 inches below ACES and mid-sagittal plane. If you're doing this projection on a female, we're going to use a little bit more cephalic tube angle, 35 degrees. And you really need to make sure you include both SI joints for comparison. Okay, so that is what you see here. Here is the right SI joint. Here is the left. Okay, and you can put your marker in either corner, top or bottom is fine. Probably there's a little more room in the bottom. All right, beautiful. So the point of the tube angle is to elongate and kind of open up that sacroiliac joint for better visualization. In addition to the AP, we also do obliques. So let's look at those next. Again, we typically do both obliques, right and left, for comparison. We're going to do a 10 by 12 inch portrait image of both right and left sides. And where do we center? We center 1 inch medial to the upside ACES. So you position the patient in a 30-degree oblique. So in this case, the patient is in a 30-degree LPO. We're always visualizing the SI joint away from the image receptor. So let's look at this diagram for a second. Here is your SI joints. Okay, in the body, they sit at 30-degree angles. So to visualize that joint space open and perpendicular to the image receptor, you have to turn the patient 30 degrees. So if I rotate my patient into a 30-degree LPO, now look, I can see right through that right SI joint. If I did a 30-degree RPO, then my left SI joint would be open and visualized. So you're always looking at the side up or the side away from the image receptor. Okay, so the patient's oblique 30 degrees, you're looking at the side that's elevated or away from the table, and we always do bilateral for comparison. So how do we know we're correctly positioned? Well, the SI joint on the side of interest should appear open and elongated. Okay, so you want to see that joint space really nicely. So remember, a 30-degree RPO will show the left SI joint. A 30-degree LPO will show the right. You're always looking at the side up. And when you're imaging SI joints, don't forget, you're always going to do that AP with the cephalic tube angle, and then you're always going to do both obliques. So you're doing 3 images for the SI joints. Okay. All right, so that concludes the 8 projections that I need you to know for checkoffs. The next 5 projections are not required for checkoffs, but I need you to know them for the exam. And we're going to start with the outlet. So the outlet is much like a pelvis. In fact, the positioning is very similar. We're going to use 14 by 17 inch landscape collimation or orientation, 45 inches SID. The difference here is we're adding a tube angle. So notice we're going to use 20 to 35 degrees cephalic for men and 30 to 45 degrees cephalic for women. And the tube angle difference is because of the differences in the male and female pelvises, which we'll talk more about in lecture. You're going to center 1 to 2 inches below the top of the pubic symphysis. So here's pubic symphysis. Here's the top of pubic symphysis. We're going to center 1 to 2 inches below that. Okay, and you can kind of see that in the picture here as well. When we add our tube angle, what this projection visualizes best is the pubis and ischial regions. Okay? And I know this sounds silly, but this is how I remember it. The outlet shows where the baby comes out. Okay, so the outlet projection shows the pubic and ischial regions really, really nicely. Look at how small the pelvic brim looks now, or the pelvic inlet. It looks tiny, but you can see this area really nicely and elongated. So this projection is really helpful if you're looking for a pubic fracture or a rami fracture or an ischial fracture. You can see it really nicely using the outlet projection. I also need you to know that this is called the Taylor method. Okay, so the Taylor method is the outlet, and it looks at the pubic and ischial regions. So let's take a look for comparison. Here's our AP pelvis. So you can see these areas nice enough. You can see the pelvic brim and pelvic inlet. But if you were questioning, or if the physician were questioning, a very small fracture here in the pubic or ischial region, look at when you throw on that cephalic tube angle, look at how much nicer you can see this. The obturator foramens look nice and large. So as a technologist, I need you to look at these two images and recognize that this is not a normal AP pelvis. The wings look kind of foreshortened here now with the tube angle. So I need you to know the differences. If I were to show you these two images, I need you to know that this is a true AP pelvis, whereas this is an outlet, or the Taylor method. Good. Let's next look at the inlet. So the inlet shows us that pelvic brim, or that pelvic inlet, really nicely. It's the opposite of the outlet. And because it's the opposite of the outlet, now we're going to use a caudal tube angle. So you still use 14 by 17 inch landscape, just like you would for a pelvis. This time we're centering mid-sagittal plane and ACES, so that's nice and easy. Those are two, nice and easy landmarks. However, we're using a 40-degree caudal tube angle on males and females. The purpose of this is to visualize this pelvic brim, and this is a nice projection in a trauma situation if you're looking for a pelvic ring fracture. So notice you can see the diagram here. We are directing our tube angle caudally to be perpendicular to the plane of the inlet. Okay, and we're centering at ACES and mid-sagittal plane. Now, look at how small the pubic and ischial regions look. Look at how small the obturator foramens look. So again, you should be able to look at these two x-rays and identify which one is the pelvis and which one is the inlet. Okay, and hopefully you said the pelvis is on the left and the inlet is on the right. Okay. All right, good. The Judet. I love the Judet, and many people say Judette, and that's okay. I call it Judet. We're going to use a 14 by 17 inch landscape image receptor, just like a pelvis. We are centering 2 inches below ACES and mid-sagittal plane. Now, Judet confuses people, but let's just call it what it is. This is a 45-degree oblique of the pelvis. That's all this is. You put the patient in a 45-degree oblique and you do a pelvis x-ray. Now, of course, the physicians are looking at more than, they're looking at all these little intricate details, which we'll talk about in a second, but don't let this overwhelm you. It's just a 45-degree oblique of the pelvis. The purpose of the Judet is to look at the acetabulum. Remember, the acetabulum is kind of that cup here where all 3 hip bones kind of meet, and it forms kind of that cup where the femoral head articulates. So I need you to know that. The purpose of the Judet is to visualize the acetabulum. Okay? Now, we're always going to do bilateral obliques for comparison. So we're going to do a 45-degree RPO and a 45-degree LPO. Couple things I want you to look at. This position, or this patient, this x-ray, is a 45-degree RPO. Look at what happens to our wing when we are laying on that side. So in other words, the wing of the side down is nice and flat. The wing of the side away from the image receptor appears foreshortened. So you should be able to look at this x-ray, and if it's hung correctly and marked correctly, you should be able to say, oh, that's an RPO. The right wing is flat, the left wing is foreshortened. Okay, so that's something I want you to recognize as a technologist. The RPO, which is what we see here, will show us the right anterior acetabulum. So in other words, here is anterior acetabulum. So you're seeing the anterior acetabulum of the side down. However, look, in the side elevated or the side away from the image receptor, you're seeing posterior acetabulum. Okay, that's why we include both sides for comparison. Because you might be thinking, why do we need a 14 by 17 inch image receptor just to look at this little tiny acetabulum? Well, it's because we want to see both sides for comparison. So the side down shows anterior acetabulum, the side up shows posterior acetabulum, and we always do both for comparison. Again, a flat wing indicates this is the side down. The foreshortened wing is the side up or away from the image receptor. And look at the obturator foramens. They're opposites. So the side down, you can't even see the obturator foramen. The side elevated, now the obturator foramen is actually parallel to the image receptor. It appears open. A lot of times we forget about this. We don't think that the obturator foramens actually sit at an angle in our body. So the pubic and the ischial bones sit at an angle. And when you oblate the patient, it then either places the obturator foramen parallel or it closes it off completely visually. So I'm going to show you some really cool examples in lab where we'll kind of study this wing and obturator foramen relationship, but please just know they're opposites. The wing that's down is flat and the obturator foramen is closed. The wing that's up is foreshortened and the obturator foramen is open. So there's so much to unpack about a Jude. So just know it's a 45-degree oblique of the pelvis. We're looking at the acetabulum. I don't so much need you to know which part of the acetabulum we see in each projection. I just kind of wanted to introduce that so you're aware. Okay. Okay. Moving on to the TOEFL. The TOEFL is also done to visualize the acetabulum. This time we're doing 10 by 12 portraits, so we're only doing the unilateral affected side. We're not doing both sides. And we're going to center about 1 inch above the greater trochanter. Okay, so greater trochanter is going to be right about here. We're centering about 1 inch above. And then if you find mid-sagittal plane, we're centering about 2 inches lateral to mid-sagittal plane. So the TOEFL visualizes the acetabulum, but this is a PA axial oblique. So in other words, the patient is in a 35 to 40 degree anterior oblique. So here they're in an LAO, which means we're looking at the left acetabulum. Okay. This is an axial projection because we are going to add a 12-degree cephalic tube angle. Remember, axial refers to a tube angle greater than 10 degrees along the long axis of the body. The TOEFL shows the posterior and superior walls of the acetabulum, as well as the fovea capitis. Okay, so again, we're not checking off on the TOEFL. I just need you to know it's an alternative to the Jude in that it's a PA done to visualize the acetabulum. The other difference between the TOEFL and the Jude is that the TOEFL uses a 12-degree cephalic tube angle. Okay, the TOEFL we do anterior obliques, the Jude we do posterior obliques. All right, Last one, Clements Nakayama. So you may see patients come into the emergency department who have had bilateral trauma to their proximal femurs. In other words, we're concerned about bilateral hip fractures. Well, we know when we do the Danelius-Miller method, we have to lift a good leg out of the way to visualize the affected side. Well, if you're questioning bilateral hip fractures, you can't lift a good leg. There is no good leg to lift, right? So the Clements-Nakayama is an alternative for patients that have limited movement of both lower limbs. So we're going to do 10 by 12 landscape, 45 inches SID, and we're going to center at mid-femoral neck. So very similar to our Danelius-Miller method. This time, we are going to pull out our Bucky and rest our image receptor on our Bucky tray. And it's difficult to see here, but the Bucky is pulled out and the image receptor is standing on top of the Bucky. So maybe you use a sandbag to kind of hold it in place. You're going to tilt the cassette or the image receptor 15 degrees posteriorly, and that's to compensate for the lack of the internal leg rotation. Remember, if we're questioning a fracture, we're not going to have the patients rotate their legs, right? So if we tilt our image receptor 15 degrees posteriorly in the Bucky, that will help compensate for that lack of internal leg rotation. We're also going to add a 15 to 20 degree downward tube angle, downward or posterior. Now this seems like a lot, and it kind of is, but the end result should look very similar to your Danelius-Miller. You see here is the acetabulum and the femoral head, the femoral neck, the trochanters, and then the proximal 1/3 of the femur. Now, I just need you to know that the Clements-Nakayama is an alternative to the Danelius-Miller for patients with limited movement of both lower limbs. That's what I need you to know. If you had to do this projection, you could certainly get out your textbook at clinicals and review before you begin, okay? Okay, certainly if you have any questions, let me know. This has been a lot of information, so thanks for hanging in there with me, and take care.